morning, everyone. I was going to say, you're such a well-behaved crowd. There was such a natural lull that I think felt compelled to start on time. Thank you very much, all of you, for coming this morning. I'm Shelley Hearn. I oversee the Big Cities Health Coalition. And before I get into the details about big cities and our wonderful panel that we have to talk about one of the most vexing public health challenges going on in our cities right now, I'd like to first thank our honorary host, Senator Markey, and his staff for really some wonderful work in helping make this happen. And in fact, we'll have a few words on behalf of that. Good morning. Did you know that I'm going to have you say a few words? Come on up.
Hi, good morning. I'm Avenel Joseph with Senator Ed Markey's office. It's nice to see some familiar faces in the audience. I'm very excited to be here with the Big Cities Health Coalition. I know this is going to be a very informative briefing. We all know the statistics. Hi, Daniel. Every day we lose 100 Americans to drug overdoses. Nationwide, overdoses are the leading cause of injury, death, far surpassing car accidents. And in the state of Massachusetts, it far surpasses both car accidents and homicides. So this is a major public health crisis that we're dealing with. The people in this room are on the front lines of fighting this epidemic every day. They know the daily tragedies of addiction that are playing out on our sidewalks, in cars and parking lots, in emergency rooms, and silently in homes all across our cities. This dramatic rise in addiction to heroin and prescription drugs is nothing less than catastrophic. And the magnitude of the harm that it's causing our neighborhoods is nothing less and nothing short of an epidemic. Heroin and prescription drug addiction is an equal opportunity destroyer of lives. It doesn't really pay any attention to age, to race, to gender, to socioeconomic status. It doesn't care about your political party, your job, or your family ties, which is why it's our moral responsibility to respond immediately and swiftly. There's some good news. Slowly, people are coming out of the shadows, no longer afraid to talk about their battles with substance use disorders. And for those who have worked in this field for generations, reducing the stigma and fostering an open discussion about substance use disorders as a public health crisis is really key. But there's still so much more that we're left to do. Even as we strive to prevent new addictions and develop effective cures, we can't wait to reduce the harms of addiction today. First, to prevent overdose deaths, we must expand access to Narcan, also known as naloxone, to save lives for first responders and for bystanders. We know that Narcan is incredibly effective. We know that it's safe. We know that it saves lives. And we know that many times those that are in the best position to intervene in an overdose are family, friends, and loved ones. Unfortunately, today only a handful of states across the country have specific laws that protect non-medical first responders or bystanders who administer Narcan from civil liability. No one should be afraid to save a life because of legal liability. Senator Markey has introduced the Opioid Overdose Reduction Act, which extends civil liability protections to people who step in to save a life of a person who is overdosing by administering a drug like Narcan or naloxone. This removes a major impediment to saving lives. We also know that the most effective way to reduce the number of people who are overdosing is to expand access to treatments that work. Breaking the cycle of addiction really lies solely with the ability to appropriately care for and treat those with substance use disorders. Currently, there are outdated laws on our books that restrict severely access to evidence-based treatment for substance use disorders. Senator Markey has recently introduced the TREAT Act to help increase the number of patients who have access to medication-assisted therapies. This bill fills an important gap in service delivery and helps give our healthcare professionals the tools they need to more effectively care for our patients that have substance use disorders. These bills are great first steps, but we know that there's no silver bullet to a disease as complex as opioid addiction. We need a comprehensive approach, one that integrates prevention, treatment, and enforcement to solve this problem. We need to bring together science, medicine, public health, and law enforcement to comprehensively address the epidemic that is tearing our families apart and tearing our neighborhoods apart. I know my boss will continue to be working diligently on this problem and looks forward to working with the experts and colleagues in this room in developing real comprehensive national plan. I look forward to hearing from our panelists today and who are really, really, truly on the front lines in dealing with this in our cities. So thank you very much for having me here.
Well, thank you very much, and thank you to Senator Markey for his leadership. You did such a good job on an introduction that I'm going to cut short many of the points I made, because it really boils down to the Big Cities Health Coalition, which represents the 20 largest health officials, not the largest health officials, but the largest, don't take that wrong, the largest metropolitan areas in the country. Their health officials are represented by the Big Cities Health Coalition. That's 1 in 7 Americans that they are a very important voice for. And as Avenel pointed out, they are truly at the front lines of many health crises, but in particular, this vaccine challenging problem of opioid addiction, overuse, and overdose. I was going to give you several numbers. Avenel listed quite a few, but they've actually been eclipsed already today. One day, and we've got new numbers. And if you're ready, CDC just released a report, came out this morning, that where I was going to tell you that the numbers of deaths due to opioid overdose have tripled since 1999, it's now quadrupled. That's how fast growing and challenging this epidemic is. The CDC's National Center for Statistics has come out with a whole new set that shows it is even worse than we had thought and imagined, which really makes today even more important. What you're going to hear from our health leaders is the realities of how they're trying to innovate, the fixes, the solutions that they are coming up with, and it's an incredible range of ideas and strategies, many of them that have been cherry-picked, not only being incorporated into the Markey bill, but also states around the country have been picking up and using. But the cities here are to tell about what they've been doing so that others can follow their lead and start to incorporate those strategies. But simultaneously, our cities have run into some roadblocks. They have been stymied from some of the further success and activities that are needed to really make a further dent on this growing epidemic. And that's why we're here today, not only to talk to Congress, but we'll be meeting this afternoon with the White House Office of National Drug Policy Control to discuss these issues, to look at where we can find common strategies and find real partnerships that can make a difference to fill this gaping wounds that we have, and not just approach this with some of the piecemeal band-aids that we've had out there. So let me turn to the boots on the ground, the hardworking city leaders who are truly not just leaders of their health departments, but I'm going to use this word over and over. This is where innovation is happening, and this is where the key spotlight investments are needed to really further this leadership. We're first going to hear from Dr. Mary Travis Bassett, who leads the New York City Department of Health and Mental Hygiene. Many of us have known her long in the field for her remarkable work on AIDS, health equity, long-time history with the New York City Health Department, and very happy to have her at the helm. She'll be followed by Dr. Bashara Shukhair, who is truly an innovation leader, has really reinvigorated the Chicago Department of Public Health, putting Chicago on the map as one of the growing, I would say, one of the healthiest cities in terms of innovations, ideas, and leadership that we've seen there. Cleanup hitter is, there's no Boston Red Sox comments going on or anything.
Yeah, let's not.
Yeah. Go Nats. Well, it is, we have to have a little more controversy up here. Barbara Ferrer is a wonderful leader, not just of the Boston Public Health Mission, but she has also been chairing the Big Cities Health Coalition in our inaugural year here at NACCHO, National Association of County and City Health Officials. And with Bashara as vice chair, it's been a wonderful duo of really making sure that the work that's going on in these cities, many of them that are the largest excuse me, health departments in the country, are really starting to get showcased and heard here in Washington. I want to thank Barbara for her leadership. I'm not going to get maudlin and sad because Barbara will be departing in the near future. It did sound maudlin, but to take on some other charges, and we're just very glad to have her as part of this team. This is our team of innovators, our leaders. Mary, I'm going to ask you to come up and start the tale.
Thank you, Shelley, for that introduction, and good morning, everyone. I'm Dr. Mary Bassett. I'm the Health Commissioner from New York City. I'd like to start out by thanking Senator Markey for hosting us here today, and to NACCHO, thanks for helping to put this panel together. It's an honor to be here with my colleagues. As you've heard, we represent some of our country's largest and most innovative health departments, and today we're here to speak with you on the topic of opioid addiction and overdose, a public health issue that is of great concern to our nation. You've just heard the new statistics, and also to the big cities, and to my city, New York City. I was going to leave this out, but let me just say a word of sort of some definitions that we consider both opioid analgesics, which we commonly call prescription painkillers, and heroin. Because they're chemically similar, we class them all together as and call them opioids. So when I speak about opioids, I'm speaking both about prescription painkillers and heroin, and the health consequences and the public health response that we have been developing to both of them. Prescription painkillers have been increasing as a cause of death, and it constitutes a national and local health crisis. In New York City, between 2000 and 2013, the rates of overdose death from prescription painkillers increased over 250%. That means between a 3- and 4-fold increase. And last year, a New Yorker died on average every other day from overdose from prescription painkillers. Like other cities, we have also seen an increase in heroin overdose deaths, which remain the most common cause of death from opioid-related deaths. Between 2010 and 2013, the rates of heroin overdose deaths began to increase in New York after 4 successive years of decline, and they have more than doubled. So the important thing for us to get across to all of you is that these opioid-related overdose deaths are virtually all preventable. And in New York City, we've adopted a basket of approaches that we use as a multi-pronged approach to this public health crisis. They include putting together an innovative surveillance system, promoting safe and judicious opioid prescribing, the promotion of naloxone or Narcan for overdose prevention, improving, and this is very important, access to addiction treatment, and last, educating the public through media campaigns. Our surveillance systems gives us near real-time picture of drug use in the city. It allowed us to identify one of our counties, Staten Island, as the site of a hot spot for prescription painkiller overdoses. The overdose rate in Staten Island was more than 4-fold higher than the rest of the city, and we began to really target our efforts there. One step was vigorously promoting judicious prescribing among healthcare providers. We came up with guidelines for health departments that have been adopted by 38 of our emergency departments across the city. We also came up with primary care guidelines. And in Staten Island, the hot spot that I mentioned, we went office to office with this packet of information, visiting more than 1,000 healthcare providers in Staten Island to educate them about judicious prescribing of opioids. We're happy that our 2013 data shows some good news. So although overdose deaths have continued to increase in New York City, that increase has slowed. And in Staten Island, where we vigorously tackled the problem of prescription painkiller use and misuse, there was a 32%, so that's nearly a third, reduction in overdose deaths in Staten Island. So we really can, through a combination of efforts, bend the curve. Since 2009, we've worked to ensure that naloxone is available to the family and friends of New Yorkers who are at risk for overdose because they're mired in addiction. And we have provided overdose prevention training to these New Yorkers. We are lucky in New York that we have two laws, the 2006 Overdose Prevention Act and the 2011 Good Samaritan Act, that enables us to do this. In addition to funding training that seeks to reach the social networks of New Yorkers who are at risk for overdose, we are working with other first responders. A pilot project with the New York City Police Department has enabled police officers to reverse overdoses. So far this year, we've seen 14 overdoses reversed. Since we began this effort with naloxone, over 500 overdose deaths potential deaths have been reversed and reported to us. We think many more have probably been reversed, but we don't hear about all of them. Still, the number of lives saved in New York and elsewhere would increase substantially if naloxone were available over the counter. But we need federal level work with the manufacturers to make this life-saving drug more available, including its availability over the counter. New York is one of 16 states in the District of Columbia that has a Good Samaritan law that protects individuals when they call 911. This is very important because people can fear drug-related prosecution, and that may prevent witnesses to an overdose from either using naloxone or even from calling for help. So we strongly support the establishment of a federal Good Samaritan law so that more lives can be saved from drug overdose without fear. Lastly, and very importantly, there's an urgent need to increase access to effective treatment for opioid addiction. Medication-assisted treatment with methadone and buprenorphine, also known as Suboxone, is the most effective way to treat opioid addiction. Buprenorphine is available in primary care, so its use has the added benefit of drawing people into overall primary care as they get treatment for addiction. But despite steps forward, buprenorphine treatment has been hindered by federal policies that limit access to this medication. The limitations include restrictions on who can prescribe it. Only physicians can prescribe it, not nurse practitioners or physician assistants. And it also limits the number of patients to whom a physician can prescribe buprenorphine at any given time, just 30 patients in the first year, and then if you make a special application, it can increase to 100 after that first year. So these restrictions limit completely unnecessarily the access to this life-saving treatment to many individuals who urgently need assistance in managing their addiction. So our department and the Big Cities Coalition asked Congress to take action so that nurse practitioners and physicians' assistants can be authorized to prescribe buprenorphine and lift the restriction on the number of patients who can be treated at any one time. These changes are included in the Markey bill, which we support. Our approach to addressing the opioid public health crisis has had some success, but much work remains to be done in New York City and across the nation. Federal policy changes that are being discussed here today are needed so urgently to address opioid addiction and to prevent unnecessary deaths from overdose. We can change this, and I thank you again for your opportunity to speak on this issue.
Thank you, Mary. Good morning, everyone. My name is Bashara Shukair, and I serve as the Commissioner for the Chicago Department of Public Health. I want to thank everybody for being here today. The epidemic of opioid abuse is really out of control. Eradicating this epidemic will require an all-hands-on-deck approach. In my remarks for the next few minutes, I'm going to be talking about how we're using that all-hands-on-deck approach in Chicago. So I'm going to be talking about the Chicago's role, the state of Illinois' role, the community-based organizations' role, as well as what we expect from the federal government role. And then I'm also going to be talking about the big pharma role in that process. So let me start by the city of Chicago. The city of Chicago is using every possible means to curb prescription of opioid abuse and to save lives from opioid and heroin overdose. Responding to an outbreak or epidemics is one of the fundamental roles of a government, which is why, for the city's part, the Chicago Fire Department, including all emergency medical technicians and paramedics, are armed with naloxone, a drug which can completely reverse the effects of an opioid overdose. The city of Chicago also participates in a drug take-back program throughout the year. Drop-off boxes are available at all of our 22 Chicago Police Department stations, where unused prescription drugs can be turned in with no questions asked. To help educate residents about drug take-back programs every year, the city of Chicago participates in the DEA's annual National Drug Take-Back effort. This year, that campaign will occur on September 27th. Illinois, as a state, also has a role, and the state government has been involved in this fight as well. The city of Chicago strongly supported the passage of a state law that established Illinois' drug overdose prevention program. This life-saving law that became effective on January 2010 makes it legal in Illinois for non-medical persons to administer naloxone to prevent an overdose from becoming fatal. It also provided Good Samaritan protection for those who administer naloxone to prevent or reverse an overdose. And it allows for standing orders, meaning a prescription for naloxone can be written even for a person the physician has not personally examined. Also in the state of Illinois, we use a broad and intense approach to educating physicians about the proper use of opioids. A state-level registry is in place to monitor prescriptions so that a physician can make sure that patients are not engaging in drug-seeking behavior like doctor shopping for opioids. Nonprofit organizations have a significant role as well. For example, in Chicago, nonprofits that run syringe exchanges, like the Chicago Recovery Alliance, also give out naloxone, and Chicago was one of the very first places to use this life-saving innovation. Nonprofit organizations, including city-funded delegate agencies, also provide substance abuse treatment to those who become addicted. And we also believe that the federal government has a role too, which is why we are all here today in Washington, D.C. sounding the alarm. Unfortunately, the drug companies who make opioids are not doing their part to curb the opioid epidemic. In fact, after a year-long investigation into their practices, we are convinced the drug companies are fueling this epidemic. Specifically, drug companies engage in deceptive practices. One, they told doctors that these drugs are safe for long-term use, knowing very well that there was no evidence to support their claims, and despite evidence to the contrary. And two, they intentionally downplayed the risks of addiction. Doctors relied on this information and started prescribing these highly addicting drugs for conditions they were not intended to treat. In some of the reports, we know that 1 in 5 of every physician visits in the United States result in an opioid prescription. As a result, patients started developing tolerance, requiring more and more of the drugs. Patients started becoming addicted. Many overdosed on these drugs. In fact, the addiction to prescription opioids is so strong that many good, law-abiding residents have turned to the streets to seek out heroin where it's cheaper and easier to get. Contrary to what the industry has told doctors and patients, this is a very powerful addiction. As a result, families have been shattered, careers were lost, and lives were destroyed. This is the public health impact of the prescription opioid epidemic. Opioids are narcotics. They come with high risk of addiction, and they are to be used in extreme pain cases. These drugs were intended to treat chronic cancer pain and for end-of-life care. These drugs were never really intended to treat back pain, fibromyalgia, migraine headaches, neuropathic pain, osteoarthritis, or rheumatoid arthritis. Yet, because of the misleading medical literature and other deceitful marketing practices used by the drug makers, that is exactly how these drugs are being prescribed. And again, 1 out of every 5 physician visits in the US result in an opioid prescription. And not surprisingly, in Chicago between 2004 and 2011, we've seen a 65% increase in ED visits due to opioid misuse or abuse. That's a total of 14,811 visits in 2011 alone, and this number continues to grow. So if we are going to truly eradicate this epidemic, we believe we cannot just treat opioid abuse problem when they arise. We must also focus on the cure. We must focus more upstream, where we believe the problem starts, with the companies that are using deceptive efforts to push these drugs. And this is why Mayor Rahm Emanuel has filed a lawsuit against the 5 big pharma companies that produce these drugs. Chicago's lawsuit is a bold prevention effort that is focusing our efforts where we believe the problem starts, with the companies that are using deceptive efforts to push these drugs. If successful, the city of Chicago hopes not only to recover the millions of dollars of what we have paid for other prescription drugs, as well as the other costs of the drug companies have imposed on the city through drug addiction treatment, emergency room visit, naloxone, drug disposal, and the like. The most important goal of Mayor Emanuel's lawsuit is to require the drug companies to accurately represent the true risks and benefits of long-term use of opioids, and to re-educate the medical community and the public so that doctors and patients can make informed choices about their care. And with that, I'll turn over the mic to my colleague from Boston, who also is our wonderful chair.
Good morning and welcome. My name is Barbara Ferrer, and I want to thank everybody for coming today. I also want to extend a special thanks to Dr. Joseph and to Senator Markey for hosting us and being such a tremendous champion for individuals and families who are suffering from substance abuse disorders. I'm really proud and grateful to be a constituent of the senators as well. As Dr. Bassett and Dr. Shakir noted, opioid overdose is a problem that all of the big city health departments have been dealing with for some time. In my city, as in others, we've seen a steady increase in unintentional drug overdoses over the last decade, with a really steep increase of around 40% in just the last 2 years. Heroin and opioid mortality, deaths associated with heroin and opioid use, have increased by 60% from 2010 to 2012, with unintentional heroin overdoses and poisoning hospital patient encounters almost doubling during those 2 years. In 2010, our paramedics and EMTs administered 232 doses of Narcan. For the first 6 months alone in this year, they have already administered 425 doses. In Boston, we've taken many of the same steps as New York and Chicago, and our state has passed legislation offering protection, expanded prevention services, and expanded treatment options. We're working every day to try to find new ways to get Narcan into the hands of people who are at the highest risk of opioid overdoses. We've partnered with one of our hospital emergency rooms with the highest number of overdose patients to implement a pilot program to reach patients who have overdosed. Each patient and their family members will receive a Narcan kit and training in how to use it before they're discharged. Because as we know, people who have already had an overdose are at 2 times the risk of having another overdose and having a fatal overdose in subsequent overdoses. Folks who would show up in the emergency rooms with overdoses will also receive information about their treatment options. We're using real-time data from our emergency medical services system to identify day-of hotspots of drug activity and overdoses, to deploy our outreach resources and get Narcan into the hands of active users. When we notice that there's an increase in overdose activity in a particular part of the neighborhood, we immediately deploy a team of folks to go out, engage with the active drug users, and identify opportunities for us to assist them, particularly on preventing overdoses. We also work hand in hand with the police department to use that as an opportunity to identify whether or not we have contaminated drugs that are circulating amongst our populations of active drug users. We're also continuing, as with other cities, to train all of our emergency responders in the cities, EMS, fire, and police, and how to recognize the signs of an overdose and how to administer Narcan. We're also working with the business community, particularly those that run restaurants and have restrooms that are available to the public, again, and how to recognize signs of overdose, who to contact, and most importantly, how to take steps within their businesses to really reduce the risk of overdoses at their sites. On the treatment front, we have been fighting in the state legislature to ensure that there are fewer barriers of treatment. And I'm really pleased to say that we've been successful in eliminating pre-authorization requirements for outpatient treatment and increasing the number of days that insurance companies must pay for detox and step-down treatment. We've also deployed treatment navigators to community health centers in the city to give our healthcare providers additional expertise in getting patients into treatment. On drug take-back, we've placed prescription drug kiosks similar to Chicago at every police station in the city. These kiosks are available 24/7, and medications are turned in without any questions asked. And I'm very proud that we have the opportunity to work alongside a mayor and community partners that are deeply committed to stemming the opioid epidemic. But as you can tell, what we're doing locally isn't enough. And it isn't enough to have strong local partnerships and skilled and passionate leadership. As my colleagues have noted, this is a complicated problem that's taking its toll on families, on neighborhoods, and on city budgets. We'll continue to do the difficult work of trying to stem the epidemic on the ground, but we don't have the resources or the authority to make some of the changes that we know will have a real impact on this problem. So I am reiterating, on behalf of the Big City Coalition, that we're asking you to consider taking federal action on 3 simple things. First, we ask you to make Narcan more available. This life-saving medication, in its nasal spray form, is extremely safe and easy to use. We call on the FDA to work with manufacturers to make the drug available over the counter. This will reduce the barriers associated with going to the doctor to ask for a prescription or having to admit to your loved one that your loved one has a drug addiction problem. Second, we ask Congress to approve a federal Good Samaritan law as proposed by Senator Markey. This would enable not only first responders but also bystanders to know that they're protected from liability in the event of providing assistance at an overdose. Finally, we call on HHS to form an interagency task force to examine insurance barriers to treatment so that the promise of recovery is within the grasp of every American. And we call on Congress to approve the TREAT Act, which would expand the availability of medication-assisted treatment by increasing the number of patients a provider can see and enabling certain nurse practitioners and physician assistants to treat patients with addiction. This would radically increase the number of providers that are able to treat addiction in our cities. We thank you for your attention and for taking the time to be here today. I'm confident that if we work together, we can bring an end to the opioid epidemic. Thank you.
Thank you very much, and I am very grateful for the time. As you can imagine, it is not easy for these health leaders to leave their departments at this time, but I think this stresses the importance of these issues and the need for true federal partnership. They cannot go it alone, despite the great headway and solutions. This needs to be a hand-in-hand effort. We're borrowing from Bashara. This is all hands on deck, and we truly have to be working together on this. I'd like to turn it over to you now as an opportunity for any questions, discussion with our panelists. Yes. If you would also identify yourself and then your question.
I'm Markey, Senator Tom Udall from New Mexico. The question I have is a little bit two-tiered. So I've worked as a paramedic in Albuquerque for the last 8 years, so I've firsthand a lot of your work and seen the patients myself many times. The first part of my question relates to the pushback from a lot of people in making Narcan accessible and saying, along the same lines with needle exchange, and saying we're promoting the drug use, we're giving them the option to have home treatment, so they can use the drug more readily available because they know they have less life-threatening ramifications from it. How do you suggest that we address that population or that concern from the community? Second, my question relates to the national off-schedule prescription for electronic reporting. How do you feel about making this also a federal policy that, again, monitoring prescription across the nation so that people can't, it's a huge issue in New Mexico, the prescription shopping, physician shopping, but now we are seeing a trend in people hopping from state to state. So I'd just like to get a little bit of feedback on both of those topics.
I'm happy to talk a little bit about the first one, and I'll turn it over to someone else. One thing about Narcan is you use Narcan, you're no longer high. So if anybody who's working with active drug users, I mean that's not a desirable result of using either an opioid prescription drug or heroin, is to use a drug, overdose, then have to use Narcan and then not be high at all. And you also need to go get treatment after you use Narcan. So I have a hard time understanding the resistance to Narcan on the level of it will promote more drug use. I mean, all it really does is prevent deaths. And state after state, city after city can show you the numbers of deaths that have been prevented because people who have overdosed have had access to Narcan. And that allows them a second chance to get into recovery. So we don't see this as a drug that helps promote people using drugs since it takes away your high. What we see it as is a way to really save lives and offer people an opportunity to get connected to services so that they can begin their recovery. I'll turn it over to you, Dr. Mariah.
Well, in New York, we have a law that went into effect in August. Can you hear me? In August of last year, that requires physicians to look up the prescriptions that a patient are getting before they prescribe it's called iStop, before they prescribe an opioid analgesic. And I think that this has been effective, along with educating physicians about encountering some of the marketing strategies that you've heard of from Dr. Shukar. So I don't know much about the federal program, but it certainly makes sense to look for doctor shopping across state borders as well as within a state.
Yes, please.
Hi, I'm Barbara Tomar from the College of Emergency Physicians, and I'm encouraged by all the work it sounds like you're doing with your local hospitals and emergency departments. But a couple of just points about those state-run drug, the drug systems where you can check what people's habits are. I mean, in an area like this, where you're in a tri-state area, there's very little or no interstate. And I hear a lot from our members, and it's very, very cumbersome in a lot of states. And when you're in an emergency department, you've got to spend a lot of time. It just really adds to it. One other thing that I just wanted to mention that's somewhat ironic is through the Affordable Care Act, there's more and more emphasis on the patient experience and patient satisfaction survey. And a lot of our physicians who don't want to prescribe opioids to patients who are clearly doctor shopping get dinged on their satisfaction scores and then get called up to the front office to say, we need better prescribing scores. So there's a lot of ironies built into the system that kind of go against each other. And I just wondered if you had any sense of that.
I totally agree with you. I mean, first of all, any system that's going to allow clinicians to ascertain somebody's prescription drug habits has to be easy to use, and it particularly has to be easy to use in emergency rooms, because those of you who are in emergency rooms know that's where a lot of shopping is happening right now. A lot of people are showing up, with an injury and looking to, in fact, get another prescription. So it has to work in the emergency rooms. I think in terms of patient satisfaction, there's very interesting opportunities right now to really think about offering alternatives to prescription drugs for issues related to pain. Because I don't think any of us are asking for clinicians to not treat pain. I think we're asking for clinicians to work with patients and treat pain appropriately. And there are other ways of treating pain besides prescribing opioids. So I think, as people, particularly clinicians and patients, get more information about those alternative therapies, which tend to go against the grain of sort of if you've got something wrong with you, there's a pill. But as we start looking at sort of the alternatives and the evidence starts mounting on effective practices, biofeedback. I mean, there's lots of places where people have gone. Acupuncture, I mean, there's new evidence that comes through almost on a weekly basis now for clinicians about other ways to treat pain. So I think, we've got to both expand the teaching of those opportunities in our medical schools and our nursing schools, and we've got to talk about that more, I think, in our communities with our patients. But I think there is sort of a groundswell at this moment of support for still treating pain and still honoring the need to have high rates of satisfaction, but looking at alternatives and getting word out there about what those effective alternatives can be.
I'm a family physician, and in my practice, I had many patients who would come in and they do want the prescription painkillers, and it's a challenge. It really is a challenge, and that's why we really have to focus on how we're educating our provider community and the public. And this is part of the mayor's lawsuit, is to making sure that pharma companies are educating the public and the doctors and the prescribing providers as to the proper uses of these medications. And the challenge is when you have doctor shopping, and obviously this is an issue, that even the first time a patient comes in with some pain and they're expecting an OxyContin or oxycodone for a very first visit, that's where that first part of that relationship really needs to be built and developed. And education is extremely important part of that process.
Well, the only thing that I would add is that a key part of this judicious prescribing education that we do is educating doctors on duration of treatment for acute pain. There's the reflexive 1-week prescription is unnecessary. We recommend that the prescriptions be given in general for 3 days only. That's usually adequate to treat acute pain. And also, we've come up with this nifty app that allows doctors to translate opioid-containing prescriptions into morphine milligram equivalents, so that they can be clear about their dosing and prescribe the right dose. So all of this is as part of it, a physician being able to recognize a painkiller shopper, physicians making sensible prescribing judgments, and a physician forming a relationship with a patient, which shouldn't be in the emergency department.
I just want to tie also the two questions together. The prescription monitoring programs, the Big Cities Health Coalition has not specifically come out with a position on this, but as you know, there's both a variety of experiences. This is a great example of where the cities should be tapped into for their insights and experiences. I know that Tufts University has put out a white paper on this specific issue, but one of the points that they noted as they did their assessment is that the variability in many of these locations, the public health officials do not have access to those prescription monitoring programs. They're only law enforcement vehicles or tools, and we need to be thinking more creatively on how to take these existing systems and partner together to be more strategic. Again, another reason why we're here. Yes.
Hi, my name is Ross, it's Senator John Boone. I think it was Dr. Bassett, you spoke to the data 2000 with the limits on prescribing for physicians. The first year limit about 30 patients, and then with the waiver you move up to about 100 patients.
That's right.
So would you suggest putting the waiver, or putting the limits more on track with methadone? It's equivalent to about 300 per provider?
What we've asked for is that the number be, that the waiver, that the caps be removed.
And then with the TREAT Act, you suggest giving more education to med students going into the profession about the addiction?
Well, that's a very good idea.
Because I think about the average for national is 4 hours in the total program. So are we actually going to educate the med students, the nurse practitioners, and physician assistant students in the process? Thank you.
Point well taken. And I think that the additional point that you make that Dr. Fair didn't mention is that we do in public health consider substance use disorders to be diseases that people require treatment for, and not to be the sign of weak character. These are people in need of treatment, not people in need of punishment.
Just a point, the medications being used for treatment, while there's extensive restrictions, there are not similar restrictions on prescribing opioids in the first place.
Hi, Jeff Lorigo from the National Institute on Drug Abuse. Thank you for doing this. Following up on this point, you're focusing a lot on docs, as you should. If you look at the SEMSA data, though, you have a small minority of doctors in the country who are even able to prescribe buprenorphine in the first place with their proper training and certification. And a minority of those who have certification ever prescribe. So this isn't a question, this is me begging for your help in trying to figure out ways to get those who have chosen, for whatever the reasons are, not to prescribe, not to see these patients in the first place, to figure out how to get to these thousands of doctors who have the certification, could expand access to treatment, but aren't providing that kind of medication to patients.
I can start with just talking about the experience with the New York City Health Department, that we have been actively promoting buprenorphine training that in the Bronx, which remains the part of the city, although we have this very high rate in Staten Island, the Bronx remains the place with the longest standing heroin problem in the city. We've worked to train primary care providers and make training more available to them. Your point to go the next road to make sure that those individuals move on to actually using their training and prescribing is well taken.
Back there?
Hi, Dr. Gomez. I'm with Congressman Ruiz's office. I think we might have missed a little bit with regard to the point that was raised and the issue of press gating. The physicians don't need more education. The students don't need more education. The issue is protecting the patients, the physicians who are standing up for the patient's best interest in cases when they are addicted and are demanding drugs that are either inappropriate or dangerous, and then are held accountable as if the patient should have the right to make a decision when they're impaired. And they're not only impaired acutely in terms of intoxication, but they're impaired psychologically and need other types of help. When those physicians stand up for those issues, they are then reprimanded as having done something incorrectly. No amount of education, although that's very well intended and appropriate, to make sure that our medical students are being educated correctly, that our residents are being educated correctly, is going to protect the integrity of the practice and professionalism if we don't figure out a way to back up those people, those physicians that take that stand on behalf of patients' best interests.
Point taken.
I just would add that, of course, physicians are in a better position when there are adequate treatment access available to patients. In New York City, we're privileged that we do have adequate treatment for all this stuff. But elsewhere in the country, that's not so. And that makes the challenge of a physician confronting a patient that you described even more difficult.
Dr. Bassett, I was really interested, you talked a little bit about how New York City requires doctors check their prescription drug monitoring program database before prescribing.
One of the things that we've been concerned about is that in many cases, in states that do require that, physicians may see that there's a red flag on a particular patient and say, okay, I'm not going to prescribe that person, maybe not be the tools to link that person to the care and to reference them to appropriate continuation of care. So I wonder how you're working that in New York City to sort of make sure that patients who are dinged aren't just turned away to go shop somewhere else, but are given an opportunity to actually enter treatment and get into the appointment.
I think that, first of all, this program has been in place for just a year, so we're just beginning to learn how it's working. And the question is often asked whether it's actually driving patients to the heroin market, for example, because people can't shop for prescriptions. Our data don't support that kind of time-trend relationship between the increase in heroin use and the increase in prescription painkillers. But it seems logical that it is a risk that for a variety of reasons people might move to heroin. And your other question is, do physicians know how to refer people to effective treatment? And what I can tell you is that we're seeking to educate them, but there's no automatic kind of electronic referral process. It sounds like something that you're thinking about that occurs right now. Right now, physicians are being held to account for not becoming a part of a doctor-shopper network, and they're not being held to account for referring people to effective treatment. But in New York, we're fortunate that we have such treatment available, and we're working to educate physicians about how to do it.
You know, one thing in Boston is we've expanded our resource and referral. You know, we have a centralized resource and referral system, and we've expanded it and tried to really make sure that providers know that both they can use us, but also that their patients and their patients' families can use us. You know, right now we're working on a proposal to expand the hours so that it's pretty easy access. Because we recognize, you know, one of the deterrents to dealing with this is the amount of time it takes. If you identify that you're treating a patient with an addiction disorder, the amount of time it takes for you to do those referrals and for really making sure that someone gets connected to care can be significant, and there's often not the resources in an individual provider's, you know, organization to handle that. So we've tried to really sort of expand our own capacity as a health department to be sort of a referral and resource, centralized referral and resource center, so that every provider network doesn't have to build out their capacity, but can have an easy link into the health department's capacity there.
Actually,
Fred Brace from Project Lazarus, the big city of North Carolina. A couple of questions or one comment that you could make. From a public health perspective, are you also working with the medical societies in your state and the medical boards to encourage co-prescribing of naloxone to anybody who's likely to receive an opioid? And the same for addiction treatment and medication-assisted treatment facilities to provide that to the new employees, so that one, not only for them, but because of the environment that they live in. And then thirdly, are you addressing benzodiazepines in this issue?
I can start by just saying about the work with community-based organizations is definitely happening. So we, you know, most of the agencies that we fund directly, we work with them to making sure that naloxone is available. And the Chicago Recovery Alliance is one very good example of the work that's happening in Chicago. I'm not familiar with any work directly with the medical societies about co-prescribing of the opioid and the naloxone. I don't know if others have it. We are not doing that.
What I can tell you is we're talking about it, and it does make sense, and we think it should be encouraged. The other thing, of course, is that that places like needle exchange programs are places where we distribute naloxone, and these are also sites where we can promote access to treatment and also encourage access to naloxone. It's really important not only to get beyond the idea of first responders as the people who should have naloxone, to thinking of the importance of having the social network around an addict have access to naloxone. So, for example, at our city jail, at the visitor centers, we've been offering on-the-spot training and distributing naloxone to people who are coming to visit through our needle exchange program, through community-based organizations. So we really want to get naloxone into the hands of family and friends, and because most overdoses, there's a witness, there's somebody nearby, that somebody whose life can be saved if they have access to naloxone.
No, I was just going to say, a couple of things. One is on the naloxone. I mean, we clearly have been doing a lot of community work with this, but our big effort right now is that nobody who's had an overdose, opioid overdose, should leave an emergency room without Narcan. I mean, almost everybody does leave the emergency room without Narcan. It would be like sending somebody who had an allergic reaction to something out of and sort of the emergency room, out of an emergency room without an EpiPen. That just doesn't happen. And it shouldn't happen for people who have an overdose. In terms of the issues on benzoids, for us the biggest problem is actually folks coming into treatment programs with lots of prescriptions to reduce their anxiety. And then because we're a treatment provider as well, as, we not only do the public health side, but we also provide a lot of treatment in the city of Boston. We're really conscious of having to work a lot with the provider community around, again, prescribing patterns for active drug users or people who are really on the path to recovery, because we see a lot of abuse now in our treatment programs from people who are selling those drugs, making too many of them, disposing of them inappropriately via other people. So I agree with you, it's an issue, and if you look at our data, we've actually, at the same time that we've seen a steep increase in opioid overdoses, we're seeing an increase, not as steep, in overdoses associated with benzoids, and with a lot of what we call multi-pronged drug use.
We have time for one more question, and I keep avoiding you, so go ahead.
Alex Zane from Congressman Crumler's office in Colorado. For those of us that don't have a medical background, I didn't know if you could shed a little light. I've heard you talk about both naloxone and Narcan.
Same thing. One's the brand name, the other's the false.
So then my primary question was, then can you talk a little bit more about the cost of those services and what kind of economic impact you see from providing them a lot in your city open?
I don't know what it costs. It's for us
$25.
Really?
Yeah, and I will say, one interesting note is our State Department of Public Health has just notified us all that their distributor has no more Narcan, and they will not be distributing, they will not be getting another shipment until the middle of November. Fortunately for us as a health department, we also run emergency medical services, and we're able to do a separate order through emergency medical services to fill in that gap. But there is a big problem right now as people have expanded programming. We definitely have seen a price increase, which has been significant, and we've also now are starting to have a problem on shortages. I think you bring up a really good issue.
We distributed in with there are 2 doses per kit, so it's $50 a kit, which is a bargain. And do you have your Medicaid reimbursed for it?
Yeah, we're working. I mean, obviously, one of the issues that has to be worked out when you do something over the counter is will in fact insurance and continue to reimburse. But yes, some of our insurance providers reimburse, everyone doesn't. So I think, again, an issue with private payers around what they're reimbursing for and where this falls, particularly on a tiered drug program. These are all things I think we have to look at collectively.
So what you're witnessing right here is what happens with the Big Cities Health Coalition in the sharing of information, comparing notes, strategizing on different innovations, how to implement it in different areas. There are 20 cities in total. I would love to have Phoenix and LA and Seattle and many of our others here also but I can't thank enough for these 3 city leaders to represent, be that voice of the innovations that are going on. And most importantly, we need to be working hand in glove with our partners here at the federal level. So we welcome the questions, the follow-up engagement. Very big thank you again to Senator Markey and the staff. I also want to thank NACCHO's government relations team, Laura Hayden, Eli Briggs, Vicki Bass, for making this happen, and NACCHO really making sure that the local health departments are being heard as they're standing out there in the front lines. PR Collaboratives, thank you for making this all come together, and thank you all for being part of this dialogue.